New workforce help, such as public health nurses and paramedics, to ensure that Ontarians have timely access to testing resources in our communities. This includes broadening access points and bringing more testing sites, such as pharmacies, online, while also ramping up capacity across the provincial lab network for processing the specimens. Ontarians who have symptoms or are close contacts of confirmed positive cases or part of an outbreak investigation, as identified through the local public health unit, are the highest priority for getting tested. Those are the ones we need to make sure are getting tested as quickly as possible in order to slow the spread of COVID-19. As well, we are looking at eligibility for testing for asymptomatic individuals who are part of targeted testing initiatives as directed by the Ministry of Health. While we expand access points across the province, we are also working to ensure the capacity we have built in our provincial lab network is used for the best purposes available to support public health objectives. We're listening to the advice from our medical community, our science table, and the testing strategy expert panel, and making changes to Ontario's testing guidance in order to ensure that our test processing capacity is available for those who need it most, and that will help us to slow the spread of COVID-19. Publicly funded testing will target those who are symptomatic, those who have had close contact with a confirmed case or are part of an outbreak investigation, or those at higher risk as designated in the targeted initiatives. Doing this will help support access to testing for those who need it and help us to prevent and control the spread of COVID-19 in Ontario. My colleagues, Matt Anderson from Ontario Health, Dr. Vanessa Allen from Public Health Ontario, and Dr. Dirk Huyer are here with me, and we would be pleased to take your questions. Thank you.
Just a reminder, one question, one follow-up. Over to the first question, please.
Your first question comes from Randy Rath with CHCH TV. Please go ahead.
Yeah, hi, doctors. I'm just wondering about the type of testing that's being done in the province's drugstores. It's a less invasive, shallow nasal swab. Isn't that going to, well, first, are you going to spread that shallow nasal swab test to the other testing locations because it's less invasive and more comfortable? And also, are you not worried that people are going to be reluctant to go to the testing facilities that are out there now and try to go to shoppers regardless of their symptom status because it's a less invasive and more comfortable test?
I'm going to refer the question, I guess, about the specific tests to Dr. Allen, and then Mr. Anderson may want to speak about which tests are going to be done where. So first, Dr. Allen, thank you.
Thank you very much for the question. So in terms of the types of tests, the test that is the mainstay currently of the provincial response and globally is a lab-based PCR test. You are completely right. There are different mechanisms or methods of collecting the sample, and the classic one has been a nasopharyngeal swab. There are newer collection ways to collect specimens, and that includes a nasal swab. It is recommended for individuals that are not very ill, but we are exploring other methods of specimen collection. So saliva is another mechanism that is being actively pursued to enhance access. And much of the focus on the diagnostic network and the response is increasing access to those who need testing quickly and rapidly for effective action, both at an individual level and at a population health level. So with respect to the nasal swab specifically in the pharmacies, it does perform well, not quite as well as a nasopharyngeal swab, but it is a reasonable alternative. And with that, I'll pass it over to Matt Anderson about its use in the assessment centers. Thank you.
Thank you, Dr. Allen, and good morning. I was going to speak more specifically to the second part of the question in terms of the concerns of symptomatic people going into pharmacies. This is why the pharmacies will be doing scheduled, so they will not be walk-in. And at that schedule, when they're doing the scheduling, there's a screening process that can go on. Anybody who is judged as symptomatic or at risk will be instructed to go to an assessment center instead of the pharmacy. Thank you.
Follow-up?
Yes, thank you. Also, just a more general question. Do you have a better understanding now than we did several months ago about why some people are affected so dramatically by COVID-19 and some aren't, and some will remain asymptomatic?
I think we are continuing to learn more about this new infection every day based on what's happening here and across the country and across the world. What we do know is that people who are older tend to get more serious infection. And of course, one says, well, how old is older? And it starts at around 50 and it starts to go up. It gets very high risk, 80 plus. The other thing is people with underlying conditions, chronic health conditions, are more at risk. Children do not seem to be seriously affected in general. But we're still learning. What are the factors that make somebody more susceptible to a serious infection? But at this point, those are the ones we're aware of.
Next question.
Your next question comes from Ashley Legasic with News Talk 1010. Please go ahead.
Hi, doctors. Thank you for taking my question. For some time now, we've been hearing that any Ontarian who wants a test can get a test. Is the tone changing now? Should low-risk, asymptomatic patients with no known exposures be getting tested at all, even at pharmacies?
I will give a general answer and then turn it over to Dr. Huyer. I think our focus as we move into, what is looking like the second wave, we are learning from what happened last spring with the first wave. And we know that over the summer, when we opened up testing to anybody who wanted it, we did not find cases. So right now, we need to focus on people who are symptomatic, people who are contacts, people in outbreaks, or in very specific populations where we have designated that testing needs to occur. So I'm going to turn over to Dr. Huyer. Thank you.
Thank you, Dr. Yaffe, and good morning to everybody. As many of you know, I was involved with my colleagues here in some of the work around testing earlier in the year, and at that point, there was a broad testing that was done in various aspects across the population, and that was to determine and understand whether there was wide community spread and wide community presence of COVID-19. What we learned was there wasn't, and it was very important and very key for us to understand that. And in fact, that's also been supported by the serology studies that have been done, which showed about a 1%, a little bit less, but about a 1% presence of antibodies. Again, showing that we did a good job. The medical officers of health, the population, those across Ontario did the best they could to keep the spread down, and we saw the numbers go down. We're seeing the numbers go up now, and that's concerning. We're at a different time in where we were, or compared to where we were in the spring, and we need to be nimble, we need to be responsive, and we need to make appropriate changes to ensure that we test those who need the tests. It's, as I say, a different time in the disease. Those with symptoms, those who are at risk from a contact with somebody who's positive, and those who need the test are crucial to ensure that we have that opportunity for them to do that. We want to protect our schools. We want to protect the long-term care homes. And this is a journey that we've learned so much on and continue to learn on. So this is the approach that we're taking at this point now. Thank you.
Follow up?
Thank you. That segues into my next question, which is about lab capacity. So, of course, this kind of transition sounds like it will, in essence, help free up some of that lab space. But I'm just wondering, Dr. Yaffe, and if any of the other doctors would like to jump in here, I'm wondering if we could get specifics on why there is such a wait time with labs. Is it lack of staff? Is it just too much demand? And what exactly has been and is being done to address that?
I'm going to turn it over to Mr. Anderson.
Great. Thank you for the question. Thank you, Dr. Yaffe. So I'm going to just pull that question apart a little bit and make sure we understand there's two parts to this process. There's specimen collection that goes on at our assessment centers, and then there is lab processing that goes on in behind that actually produces the result of the test. The lab processing is what sets the pace for our capacity. And then we can take on or add, if we need to, on the specimen collection. Specifically on lab capacity, we've been working to build up our lab capacity since really early March. We've seen about a 350% increase in our total lab capacity. We continue to try to build more and more lab capacity. You've heard the Premier and our health minister speak about that quite regularly. The main drivers behind our lab capacity are threefold. We need to ensure and continue to acquire more equipment, which is all underway. We also need to work with our global supply chain right now. As you can imagine, all across the world, everyone is bringing on more testing capacity. So global supply chain remains a challenge for us, but that can be a rate limiter for us. And the third is on our human resources. And just to do a quick shout out to our lab techs all across this province who are working night and day to try to enhance and build up that capacity that we've been talking about. So that capacity will continue to grow, and we have intention, and we've been supported by the government to continue to grow the capacity throughout this season and into the new year. One other comment that I would make, and I think I will go just pick up on one of the comments that Dr. Allen made earlier. The other thing that will assist us as we build up that capacity are as other technologies come online. As you heard from Dr. Allen, this particular technology, lab process, is sort of the gold standard for diagnostics. We are working to see if there's other modalities or other types of tests that can come on that will help us build that capacity even faster. Thank you.
Next question.
Your next question comes from Chris Herholt with CP24. Please go ahead.
Hello, doctors. Where does this guidance leave the requirements for negative tests before visiting long-term care homes? Can those people still attend assessment centers, or are they going to be moved to pharmacies now?
Those requirements, as set out by the Ministry of Long-Term Care, are part of the targeted testing that can go to an assessment center or can go to a pharmacy at this point. Well, the pharmacies don't start till tomorrow, and that's being expanded, but they can go to an assessment center. Yes.
Follow up?
Okay, and this is for all of you. Right now, when can you predict our daily capacity for PCR test turnaround can reach 50,000? Minister Elliott said earlier this week that we could hit 50,000 sometime in the next 2 weeks. Is this feasible or reasonable?
Okay, I think Mr. Anderson is coming back.
Great, thank you for the question. So we continue to work towards the 50,000 goal. We're very close to it now. We are struggling a bit with some of our supply chain challenges. We continue to build that capacity out and do expect that we will be in that range within the next couple of weeks. Thank you.
Next question.
Your next question comes from Sean Jeffords with the Canadian Press. Looks like Mr. Jeffords has disconnected. Your next question comes from Brian Lilly with the Toronto Sun. Please go ahead.
For Yaffe, there's a group of physicians out today calling for the province to start ending dine-in eating at restaurants, have all non-essential workers work from home, effectively in many ways going back to a stage 1 or stage 2, where we were back in the spring. Dr. Tam and the World Health Organization have been saying that, in fact, any outbreaks can be dealt with on a targeted basis, that we don't need lockdowns anymore. What's your opinion on these two different viewpoints, and what's the public to make of it when they're hearing different medical experts?
Thank you for that question. Yes, we are taking more of a targeted approach. We have to look at the benefits and risks when you close facilities, when you close restaurants and other businesses. Obviously, it has an economic impact, a social impact on people that also affects their health very seriously. So we're trying to look at the data and say where is the transmission happening and how can we reduce the transmission. Sometimes it's not just the places, it's people's behavior in the places as well. So we have a public health measures table that has representation from physicians, public health people, other people looking at the data and saying, where are we seeing transmission, and making recommendations to government on next steps. But in a very general way, I would say at this point, people should be thinking about every interaction they have with other people. And if it's not somebody in your social bubble, somebody you're close with, that small group, think about it and remember that if you're closer than 6 feet to them, you should be wearing a mask. Like, think about it everywhere, everything you're doing. It doesn't matter where you are. And that's really the message.
Other members of the health table looked at on whether there was an increase across Ontario in terms of overdoses and other negative health outcomes as a result of the lockdown that we went into. And if so, how does that factor into your ongoing deliberations?
Well, our table hasn't specifically looked at that, but we are certainly aware of that. And Dr. Huyer may want to speak to the overdose specific situation, but there are many looking at the other ill effects, mental health, suicide, overdose, all sorts of other negative effects that have happened either from the infection itself or the measures that have been put in place to control the infection. So we always have to keep this in mind as we decide, as we make recommendations on what to do. We cannot just close down everything and assume everything will be fine. I don't know if Dr. Huyer might want to speak to the overdose question. Thank you.
So thank you, Dr. Yaffe. A couple of points. One, the question about outbreaks, and clearly that is fundamental to the work that we're doing together and fundamentally supported by the work of making sure that those who need tests are going to get tests. Because as you heard, you asked about the two different medical opinions. There's a number of opinions that people have. People are trying to help. People are all working together, and people are trying to make a difference to stop this disease and to do our best to make sure that people stay well. everybody needs to be considered, and their voices need to be thought together, and people should continue to work together to come up with the best possible solutions. So this is an example of a decision that's being made informed by what's happening within COVID to help focus on outbreaks, focus on those with symptoms, and ensure that we're taking the best steps to maintain the second part of the question, which is how do we make decisions about opening and closing certain establishments. Stepping into my other role as the chief coroner, we are unfortunately seeing an incredibly increased number of deaths from drug toxicity, and the number is upwards of 35 to 40% higher than we've seen for a number of, since the pandemic started compared to last year's number. And last year's number was not reduced. So this is not something that has been improving, unfortunately. And not only is it people who die, and when we talk about this, these are individuals, and everybody needs to remember this is one person that's dying, and the number is overwhelming, but these are many individuals who families, communities, loved ones, friends have lost. So we are working together with the Centre of Excellence at the Ontario Health to look at best ways to understand what is currently what strategies are in place to try to respond to this in the most effective way. It's very complex, and that's an easy way to say things, but it's true. And there are many people who are working together to try to understand how an intervention can be done in the most effective way. There have been some significant innovations, as I understand, that have been taken by those who are specializing in addiction and medicine, and also those who help to provide supports to people who use drugs, and people who are providing care, and those who have lived experience to try to find ways to approach this. We need to do more, and we continue to work together to try to find the best answers possible about what's happening, but then most importantly, what can we do to reduce this terrible tragedy.
Next question.
Your next question comes from Allison Martel with Reuters. Please go ahead.
Thanks. Can you tell me what proportion of molecular tests in the province are done by private labs right now?
I think Dr. Allen maybe will answer that. Okay, thanks.
Thank you for the question. So the diagnostic network is made up of commercial labs, hospital labs, and Public Health Ontario labs, and it really was and continues to be a rapid integration of a system that really didn't exist before. The community labs contribute anywhere between 10% to 15%, and they have been an incredible partner as we go forward and have really enabled, like the other parts of the system, for us to be as responsive and really meet the needs of turnaround time that we need for these scenarios, like individuals who are in hospitals, outbreaks, etc. So I think it's a testament to the common cause, and really understanding that it requires the expertise across the sectors to be able to deliver what Ontario needs. Thank you.
Follow up.
Did their roles reduce at all once the NHL was doing their testing here?
They have continued to deliver the same amount of testing and continue to grow their amount of testing for the contribution to the network. And they have, in fact, advanced some of the methods of specimen collection that we discussed earlier, along with our hospital partners. So I think it really has been a coordinated system, and to my knowledge there was no impact at the time of that other testing, and we continue to drive the overall capacity for public health needs.
Next question.
Your next question comes from John McGrath with TVO. Please go ahead.
Thank you for taking my question. I'm wondering if there's any change or whether there's anything new in terms of who are high or rather low risk populations in terms of access to testing. Who is no longer going to be, or what groups will no longer be prioritized for COVID-19 tests?
Well, I mean, so far our priorities have been the same as they still are, which is people who are symptomatic, people who are contacts of known confirmed cases, and outbreaks. I think what you're asking about is asymptomatic people. And here we're looking at people who live or work in a setting where the risk may be increased, and there's a concerted policy by the Ministry of Health to do targeted testing. So, for example, currently it is long-term care, some other congregate settings, but I would say, generally speaking, people, your average person out there who, is not exposed to a case, it's not part of an outbreak, has no symptoms, should not be going for testing. There's of no value. In fact, what we found is when there's very little COVID in that group, what we end up with is false positives, which just complicates things even more and causes a lot of concern and effort that's unnecessary. What we need to do is focus on the cases and their contacts and outbreaks and get the turnaround time down so that we can actually prevent and control spread of this infection in that group.
In terms of the COVID alert app, this is my understanding is the app gives people the prompt. You've had a contact with somebody, consider getting tested. Is there going to be any modification to the software to tell people, like, you may have had a contact, but unless you are in a high-risk group, do not get tested?
No. In fact, the COVID alert, if you get an alert, that means you have been a contact of a case. And that is one of the groups that needs to get tested. So we're very much continue to encourage people to get that app on your phone so that if you are in contact with a case and you don't even know about it, you will be alerted and can go for testing.
Next question.
Your next question comes from Jeff Gray with the Globe and Mail. Please go
Hi,
ahead.
everybody. I just wanted to see if I could get some clarity on just what you're saying today. I mean, are you saying that, use the words will target or prioritize, but if I walk up to the assessment center around the corner from me today or later this week, will I be turned away if I'm trying to get a test and I don't have any symptoms or any other reason to get a test?
I think that should be happening. I'm going to ask Mr. Anderson to answer more specifically. Thanks.
Great. Thank you, Dr. Yaffe, and thank you for the question. And that is what we're talking about. We want to ensure that we have the testing capacity for our priority populations. So in the as Dr. Yaffe has described, in the case where you have not had contact, you are not symptomatic, you are not from one of the high-risk settings, we are not doing those tests now. We are going to focus on the priority populations as described by Dr. Yaffe. Thank you.
And then just maybe a two-part follow-up to that then. Do you know what percentage of people in that category were getting tests and clogging up the queue and the labs and the lineups? And is there a plan to make this communication very, very clear to people?
Back to Mr. Anderson again.
Thank you. So we don't have a number for how many people would fit into this category that are on that are in those queues. We wouldn't be collecting that at the time of the test. And on this, I'm sorry, what was the second part of the question?
I'm trying to communicate this because people are going to wait in line and then discover that they're not welcome at the test center and they're not going to be happy.
So there's going to be a full communication plan put together, also out into the assessment centers and throughout the community. And again, this is part of, and going back to a little bit of what Dr. Huyer was speaking of, back in the spring, this was our approach when we had higher activity of COVID. We focused down on those individuals who were exposed or were symptomatic. So we're going back to that model as we go through. As we see COVID activity diminish, we would expect that that we may be able to open up again. I'd also say that and bring forward the comments from Dr. Allen as well. What we're also looking for are other test modalities. So for those people who, the term that's sort of being developed now is reassurance testing. So people who aren't necessarily exposed, but they need some reassurance. And some of the other technologies that Dr. Allen spoke about earlier could give us those opportunities so that we can offer yet another option for people who are looking for that kind of testing. Thank you.
Next question.
Your next question comes from Michelle McQuigg with the Canadian Press. Please go ahead.
Hi, doctors. A quick question, just to get some clarity. So there have been a couple of different schools of thought around testing approaches. The way I've heard the province's strategy to date has been described as symptom-oriented, where you're going and targeting testing at where the symptoms are, versus risk-based testing. So that's more proactively going into areas of higher risk, which the province has done in long-term care facilities, but not necessarily in some other settings. I'd like to understand a little bit more about why you opted for the route that you've chosen, and just to get some clarity that, in fact, you are sort of leaning in harder and doubling down on the symptom-based model.
We are more on the symptom-based because the symptoms of COVID are quite non-specific. We're heading into flu season, which is going to complicate it further potentially. So if we're going to start doing follow-up on COVID, we need to know it's COVID. It's not another respiratory virus, and we would be dealing with it quite differently. So are we looking at risk-based? We are doing that as well. Long-term care, I believe the Ministry of Education is planning some targeted screening in some secondary schools in high prevalence areas. So there are various initiatives to look at risk-based testing as well. But for the general public, our focus is on symptoms, contacts, and outbreaks.
Follow-up?
Thank you. And on the question of lab capacity, what steps are you taking currently to try and expand that, since it is still an issue? I know there have been steps taken so far, but are there measures in place or talks underway to do things like perhaps make use of some of the unused university lab capacity that's out there, or perhaps investigate some other options?
I think Dr. Allen will take it. Thank you.
Thank you. That's a great question. I just want to go back, though, to our current capacity and some of the earlier discussion. I think what we're always doing is also balancing turnaround time with delivering these tests. And I think it's really making sure that those turnaround times enable action that really helps us with the response and helps with individuals. So we have examples in ICUs where people are waiting for tests and their management changes. We have outbreaks where you need those results as quickly as possible. And it's really using the tests where they're needed and with the turnaround time that is needed. And I think that is a huge theme. And it's how do we adapt to the current circumstances in the way that we make sure that we have the greatest response. And that's appropriate to a pandemic. And so really figuring out as we go forward how to do that. In the meantime, you are absolutely correct. There is incredible innovation. There are incredible partners to leverage in terms of what capacity is out there. There are several leading university labs that we are working very closely with to figure out whether we can support them in getting those tests online. That being said, there is an infrastructure we need to make sure the results get to the patients, and those are not simple pieces. And so it's making sure that it's the test plus all of the infrastructure that is required so that that test is meaningful. And so I think those have been incredible collaborations, but we need to make sure that those deliver what we need. In terms of innovation methods, so I think there's been a lot of optimism around point of care tests in many different formats. And so the two main ones are analogous to the lab test that we have now, which is a PCR test, but the other one is the antigen-based test. Both of those have not yet performed at the status at which we would expect for a diagnostic test, and this is building on what Matt Anderson described. But I think there is some optimism in terms of them being able to be used in a different way, in terms of reassurance testing or more risk-based analysis that you can do, serial testing. There is some recent advances that make it look like those are closer to being ready. We are evaluating them in real time in Ontario. We are working with our federal colleagues, and we hope that more of that capacity will be built using those technologies. Then lastly, the network itself has invested with the support of our ministry and government colleagues, invested in equipment, is hiring, is training staff to be able to do it, and it's large numbers of staff. These are over 500 people who need to be trained in the skills of a very specialized service. And so we are all committed to exploring multiple different avenues of increasing the capacity, and in the meantime, making sure that those test turnaround times are what they need to be. Thank you.
Next question.
Your next question comes from Colin DeMillo with CTV News. Please go ahead.
Hi there, Dr. Yaffe. Just a question about the number of people being turned away from the lineup. So if there are a lot of people who are turned away on a daily basis from the assessment centers, and the testing backlog is what it is right now, do you feel like we have an accurate view of community spread of COVID-19 right now?
I think we have a pretty good view of what's going on. Keeping in mind that the data we see, the test results we get now, reflect people's behavior 10 to 14 days ago, right? Because I get exposed, I get sick, I go for a test, then the test result, and for me to get infected, the period of exposure might have been up to 14 days before that. So, as best as we can, we know that we're somewhat behind because of the very nature of the infection and the way people, have to go for a test. And it's not so much the test itself that's slowing it down. It's the fact that people can be incubating for up to 14 days, and then they have to go get the test. So as best as we can, we have a pretty good picture. We see the numbers are generally going up. About 50% of our cases continue to be in the 20 to 39 age group. However, and it's primarily the dense urban areas, but we are starting to see little creeping up numbers in some of the other places across the province. And we know from experience in other jurisdictions, it may start in the young people, but it may eventually go to the older folks. And the older folks are the ones who are more at risk. So we're working very closely as well with the Ministry of Education, Long-Term Care, and other ministries to see what's going on with all the various settings, congregate settings in terms of that as well. So yes, I think we have a pretty good idea of what's going on. Thanks.
Follow up.
And just a two-part follow-up. I mean, there are probably people waiting in lineups right now as we speak. So I'm wondering, the change that is being made, is that as of right now? So people who are, let's say, almost at the front of the line, they don't have symptoms, low risk, what's going to happen? Are they actually going to be turned away without getting a test? And secondly, if asymptomatic patients are no longer being considered who are low risk, what is the point of pharmacy testing? What are they actually going to be testing, or who are they going to be testing?
I'm going to ask Matt Anderson to answer that. Thanks.
Great. Thank you again for the questions today. In terms of today, the guidance is only coming out today, so and we still have to get it out to all of the assessment centers. So my expectation would be that the assessment centers will complete today as they were, and then this will likely have more of an impact on assessment centers and lines and all those sorts of things tomorrow, just as we try to get all of this communicated out to the field in the next little while. In terms of the pharmacies, I would go back again to the comments that Dr. Yaffe made at the beginning. So we are still testing asymptomatic people. We're doing it, though, in a very targeted way. So a great example would be our long-term care workers. We do want to test them. We also test our retirement home workers. So if they're asymptomatic, they can go to the pharmacy and test through that fashion. Thank you.
Next question.
Your next question comes from Katie Nicholson with CBC News. Please go ahead.
Yeah, yesterday the Pharmacy Association sort of explained where the specimens will be going to the best of their knowledge, the guidance they got from the province. And they said that it's going to go to a central collector and that additional capacity is being created for these specimens. I'm just wondering if you could sort of explain how this is going to work. What is this central collector and where is this capacity coming from?
Mr. Anderson will answer that. Thanks.
Great, thank you for the question. So we are dedicating a certain path for those tests to try to take it offline from our main labs that we're already using. That has not been confirmed yet. That's the plan. We're still working through with various providers to see if we're able to do that. We're opening up all channels to see where can we acquire more capacity, perhaps from other provinces, perhaps from outside of the country in the U.S. But these are paths that we're looking at now. The idea is to try to channel that those asymptomatic tests in a particular way so that we can do better measurement and understand the impact that we're having there. We do anticipate that over time we will be able to commingle, if you will, those results that are coming from the pharmacies onto the main network. But this is all a work in progress as we try to do load balancing across our network. Thank you.
Follow up.
That. I do wonder, too, about the new guidance today. How do you plan to police that when folks are coming into the lineup who are asymptomatic, who don't have symptoms, and who are seeking for a test? I mean, people could fudge that. People could, not necessarily be forthcoming. So how do you plan to actually enforce this?
A very big part of this is an appeal to the public. This is, we're all in this together. And the residents of Ontario did an absolutely wonderful job back in the spring when we had similar type of testing guidance. We do rely on people. We're not going to be asking the assessment centers to police. And so when people come forward, we are asking all of the public to respect that this is what we need to do. This is what we're going to need to do to protect the most vulnerable. So although someone could come forward, I suppose, and say that they're symptomatic or something along those lines, we're really going to be counting on the public of Ontario to respect what we're trying to do and how we're trying to protect those who are most at risk. And our track record is fabulous. This is what we did in the spring. This is how Ontarians responded, and we're counting on that as we go through this wave as well. Thank you.
Next question, and this is going to be the last question.
Your final question comes from Natasha McDonald with Radio Canada. Please go ahead.
Hi. From the document, and correct me if this is not new, but you're saying that if the test result is negative, asymptomatic contacts must remain in self-isolation for 14 days from lack of exposure. I'm wondering how you're planning on communicating and enforcing this, because you could expect reasonably that a lot of people will either be reticent or outright not agree or not want to self-isolate for 14 days. How are you going to go about this?
I don't have the document in front of me. I assume you're talking about contacts of a case. The test at first may be negative, but they may have been, they were exposed, their contact. They may still be incubating, and they wouldn't have any evidence of infection if you test them at the beginning. So we know the incubation period is up to 14 days. That's why we ask for them to self-isolate for that period. If they develop symptoms during that period, they get tested. If they're fine by the end of the 14 days, that's great, back to normal life.
Follow up, and this is the last question.
The Ontario Council of Hospital Unions has expressed concerns about testing in pharmacies. So they're wondering how safe it is to have people who may have direct contact with a COVID-19 positive case heading to pharmacies. Like, does it pose a risk for community transmission, and so should seniors and at-risk individuals avoid those pharmacies?
Well, I know that the pharmacies are going to be using an appointment system. They'll be screening people before they come. If they have any symptoms, they will be redirected to an assessment center. And the pharmacies will put in a very comprehensive health and safety plan so that those people coming for COVID testing will not be mixing with other people in the pharmacy.
Thanks, everyone.
Thank you.